pleasure that I introduce a friend, someone who is a family advocate, and, well, just overall a really neat guy. So enough about that. I'd like to introduce Hugh Davis from Wisconsin Family Ties, talking to us about barriers to accessing mental health services. Thanks, Hugh.
I'll probably temper your enthusiasm after you see my presentation, Tim, but I appreciate the intro. Is there anything I need to know?
Oh, I'm sorry. You can...
What's page down? There's no page down on this. Oh, there it is right there.
Use this or this.
Okay, got it. Got it. Thank you.
Yep. And for all future speakers, you can either use this or the keys. Okay, good. We've covered that. Thank you, Hugh. My bad.
It's okay. So I got a little bit more nervous as Tim listed off all of those sites that are there, because I'm going to talk about some barriers from a parent perspective, and some of those barriers don't sound very flattering sometimes to providers, but I'm confident that every one of the providers that are here today are on the excellent end of that spectrum, so that shouldn't be a problem. But it also strikes me that the experts on this subject today are in the audience and not really the speaker. We could probably spend the whole day in conversation amongst ourselves about the barriers that people on this webcast have experienced. And I admit that I really struggled with this topic. And in the end, I decided not to focus on barriers to access that are often brought up, things like scheduling, location of providers, cost, insurance, workforce shortage. Those things have been talked about time and time again. And so today I decided to instead focus on some things that, barriers that I've experienced as the parent of a young adult with autism, as well as some things from my experience with Wisconsin Family Ties. And I actually am going to spend more of the time talking about some of the systemic barriers that we've experienced through Wisconsin Family Ties. And I apologize if I take a break every now and then to grab some water or a cough drop. I am getting over a cold. So if my voice gets a little froggy, I apologize in advance for that. So let's start first with the competence and fit of providers. You know, just like any other profession, there are good mental health practitioners, and then there are the others that are not so good. And you know, there also may be providers who are very competent but are not a good fit for your family or for your particular child. And so I tried to focus on a few things here, and I'm not going to go into great depth on those, that you may want to consider as you're either selecting or developing a relationship with a provider. So first area is skill and approach, and the thing that I think of the most is an experience that I had many years ago when my daughter was 9 years old and experiencing significant anxiety. It came on very suddenly, and it started with a stranger danger presentation at school, and within a week she was refusing to go outside and play in the backyard. So we ended up contacting some people trying to find someone who was a good fit, and we found a psychiatrist that was highly recommended. As you know, so we had this appointment. We sat down. I'm there with my 9-year-old daughter, and the psychiatrist wants us to go through a very detailed family mental health history. We have a significant mental health history, particularly on one side of the family, and that includes the suicide of my daughter's aunt. The suicide took place just before she was born, and at the age of 9, and a kid who was having anxiety, we had not broached that subject with her yet and talked to her. And so I told the psychiatrist, I'm not really comfortable in talking about all of this detailed history with my daughter here. And instead of acknowledging my concerns, he just gave me his philosophy, which was, well, I think it's a good thing for kids to hear this family history. I'm sorry, it's not your call. That's our call as parents. And so, finding out these things, and sometimes, you don't find those out ahead of time, but finding them out as you're developing a relationship, and it's okay to not go back. It's okay to find somebody else, which is what we did in that case. Another area is what I call philosophy, and when I think of philosophy around children's mental health, the thing I think of most frequently is their view of behavior. And if you look at the work of Ross Greene, he talks about really two different competing philosophies around behavior. That is, that kids do well if they can, or kids do well if they wanna. And there are practitioners out there on both sides of that fence. And if you if you subscribe to the philosophy that all my kid needs is a little bit more motivation and then he or she will do better, then that's fine to find somebody who believes in that philosophy. But if not, you're going to have an inherent conflict if you have a differing view on challenging behavior. So that's an important thing to find out as you're selecting providers. Over-reliance on medication. There actually is research that shows that providers are more likely to prescribe or recommend medication for kids on the autism spectrum than behavior therapy. So again, another thing to consider as you're looking for providers. Family-driven perspective. Do they believe that parents are part of the solution, or do they believe that parents are part of the problem? And I'll admit, as a parent, sometimes I'm both, right? But I like to think that I'm much more part of the solution than part of the problem. And how will those providers communicate with parents? The law used to be in our state that minors age 14 or above could consent or refuse mental health treatment despite the wishes of their parents. That law was changed in 2005, but we still have a number of mental health practitioners in the state who continue to operate under the tenets of the old law. So it's really important for you to understand your rights when it comes to informed consent and on whether you're going to consent for treatment or refuse certain kinds of treatment. And then finally, the thing I wanted to mention is finding people who can, who are experienced enough or have had the experience to understand some of the unique ways that people on the autism spectrum communicate. I remember when my son was 3 years old and went to the pediatrician for a well check, and the nurse told him to hop on the scale. For a kid with autism, you take that literally, and you hop on the scale. I also remember in my work at Wisconsin Family Ties a number of years ago when we were working with a team, and this was a team where Child Protective Services was involved with a family. And the mom of these kids was in this meeting, and she was relating how things were going. And in the course of that conversation, she mentioned that she and her kids had gone to visit a man at his house. Well, the child welfare worker blanched immediately and said, "What are you talking about? That was, we told you that man could not be in your house." And the professionals around the table couldn't understand why this mom would willingly talk about going to visit this man at his house when she was told that he couldn't be in her house. Well, it was clear to me, because I had a kid with autism, that those were two different things in her mind. She saw absolutely nothing wrong with going and visit the man in his house, because what she had been told was, he can't be in your house. And so, finding people who can understand those kinds of nuances in how people communicate are really important, particularly with kids who are on the autism spectrum, who tend to, I continue, my son is 22 years old, and just had another example recently with all of this weather about the difficulty in generalizing certain kinds of statements. So when the temperature was well below zero, and my son, who does have his driver's license, drives only in the local community, and he has a very part-time job about 1.5 miles away. And my wife told him on one of those days that was tremendously below zero that when you start the car, let it run for a while. All right, let it run for a while and warm up. And so he did. The next week, when it was about 40 degrees, he went out and started the car and let it run for a while. He didn't understand the context that's different when it's 40 degrees and when it's 25 below zero. Unfortunately, the day that it was 40 degrees when he did that, the car was in the garage. But he figured out quite quickly, as the exhaust started to gather in the garage, that he better open the garage. So, it could have been a tragic situation, but I've grown up with him for 22 years. I think we know him really, really well, and yet just some off-the-cuff comment was totally misinterpreted by him because he couldn't understand the context. So, enough of that. I've belabored that. So I also wanted to talk about some of the challenges when it comes to eligibility and rules around programs. And when we're talking about mental health programs in our state, the thing that pops immediately to mind is a program called Comprehensive Community Services. And the reason that is important is because about 6 years ago, the state decided in their biennial budget to cover the state would cover the non-federal portion of this Medicaid-funded program. Prior to that, in our state, mental health services, if it was a Medicaid benefit, the non-Medicaid portion, not federal portion, was always covered by counties. And so now the state picks this up. This creates a huge incentive for counties to utilize comprehensive community services as their primary mental health program, public mental health program. CCS is a program for the lifespan, so it covers from kids through adults, and it is defined and governed by an administrative rule, and that administrative rule is DH 36. If anybody wants to find out anything about it, just Google Wisconsin DH 36 and you can read that. So there are a few things that we've seen over time or heard from families as we work with them, and one of those is around the area of eligibility, where some families have been told that their child is not eligible if they have an autism diagnosis. That is not technically true. They do have to have according to the rule, a diagnosis of a mental disorder. But there's nothing that says that autism disqualifies someone for that. And quite often, they probably are looking for a more traditional mental health diagnosis. But the vast majority of kids, in fact, every kid on the autism spectrum that I've seen or worked with over the last 16 years, has co-occurring anxiety and depression. And certainly at a diagnosable level. So, so this idea of autism disqualifying somebody from being in the Comprehensive Community Services Program is not true. Also, there is a discrimination statement in the rule which says, among other things, that you can't be denied because of disability, so that you can't exclude because of autism. You do have to meet the criteria, which is, again, a mental disorder or a substance use disorder. In the second area where we've heard some concerns about barriers is in the area of service transition. And so families who have previously had services and now are going to be getting services under CCS, and some have been told that they have to give up their intensive autism service or their ABA service. And that, again, is not true, and there is a bulletin that talks about that, and I've listed it here, Forward Health Update 2014-42. You do have to use the psychotherapist that is a contracted provider in that CCS network. So if you're currently using a psychotherapist and they're not in that network, you may have to give that up, but you do not have to give up your ABA service. The next area is informed consent. When CCS was developed, it was, even though it was designed for the lifespan, it was really designed using a whole lot of adult language. Consumer is a term that is used in the mental health world. It comes from the adult mental health world, used to mean the person who is not only receiving services, but making decisions about those services. Our contention is that when it comes to the kids' world, that the service recipient and the consumer are sometimes different, that the child is the service recipient and the parent is the consumer. They're the ones who are making decisions about those services. They're the ones, in cases where there are services to be paid for, that are paying for those services. And so CCS is identified as consumer-driven, and a lot of the training that the various CCS sites get in this program emphasizes this consumer-driven perspective. Unfortunately, what we've seen happen, and this is believe it or not, a true case, there was a situation where a 7-year-old child said in a team meeting, "I don't want to do this anymore," and the CCS site disenrolled him from the program. I don't believe 7-year-olds are the ones who should be making those decisions. I think their parents ought to. And so that's something that you should be aware of and continue to push on if you have a CCS site that is having kids make decisions that are not developmentally appropriate. Interestingly enough, within the CCS rule, and I put the citation on this slide, there is a notation that says that family members are also considered consumers. So if this is consumer-driven, then it clearly needs to include the family members in that decision-making process. And finally, the thing that I want to talk about is choice. We know that there's a lack of mental health practitioners and providers throughout our state, and it's particularly challenging in certain parts of the state. But CCS does have right in the rule that there should be choice in selection of team members. That is, the people that you want to have meet periodically to look and develop a plan and assess that plan. In the services that you receive and in the providers. And so we think that that's a really important concept in CCS. It's something that's all too often not emphasized as part of the training or in the rule, but it is there, and I think choice is a really important aspect for families, particularly with kids with challenging behavior, including those on the autism spectrum. So, these webcasts are always interesting because you feel like you're just talking. I look forward to the conversation time afterwards so that we can get a little bit of feedback. But the next thing I wanted to talk about was systemic barriers. And I like this particular definition of system. I like the idea that a system creates a unified whole. I like the word harmonious. And so given this definition, let's take a look at Wisconsin's children's mental health system. So I'm going to lay out some of it's a simplified graph, but I'm going to lay out some of the elements of the children's mental health system on this graph. And the vertical axis on the left represents the degree of parental control. And the horizontal axis is the intensity of mental health needs. So we're going to look at some of the main components of the mental health system and see where they fall in terms of the degree of parental control that you have, as well as the intensity of need. All right, the first is outpatient and medication services, and this includes things like individual therapy, family therapy, group therapy, psychiatric services where your medications are managed. These are services that are typically selected by parents, and the decisions to continue are with the parents. So there's a high degree of parental control in selection and continuation of those services. The next area is called community-based support programs, and so that would be things like this, the CCS program that I talked about before. Another program that a lot of kids with mental health needs access in the state is called Coordinated Services Team Initiative, CST. So that would fall into this bucket as well. The next area, if a child's needs get to a point where they can't receive the needed care while they're at home, then we get into residential-based services. And these are things like group homes, residential care centers, therapeutic foster care. And while technically in our state, parents retain legal custody, they don't have physical custody, and in reality, they end up relinquishing quite a bit of the authority they have over their child while their child is not in their home. Unfortunately, in our state, if a child has intense needs and they have done something that can result in criminal charges, they may end up in a juvenile detention facility or in corrections and receive mental health services through those institutions. And clearly, parents are no longer making the day-to-day decisions for their child when they're in those settings. And finally, there is hospitalization, and the degree of parental control with hospitalization is really dependent on whether that's a voluntary hospitalization or an involuntary hospitalization. And I'm not going to get into the whole mechanics of Wisconsin's mental health law, which is Chapter 51, but all I wanted to do was signify that there are situations where there is involuntary hospitalization, and again, there's not a great deal of parental control in those situations. While we refer to this set or this kind of continuum of services as the children's mental health system, in reality, it is really multiple systems. For example, the residential services are part of the child welfare system. The child welfare system is primarily tasked with addressing child abuse and neglect. So if your child's needs are such that they require temporary placement outside of the home, you will have to file what's called file a CHIPS petition with the court. And CHIPS stands for Child in Need of Protection or Services, and the form typically requires you to stipulate that you are unable or unwilling to provide care for your child, which is highly offensive to parents who are simply trying to access services their child needs because of the intensity of those needs. And obviously, placement in detention or corrections is part of the juvenile justice system. There's lots of research on that reaches a conclusion that in the United States, not just here in Wisconsin, that our correction system is the de facto mental health system. And it's no different here in Wisconsin. While I don't think the Division of Juvenile Corrections is doing the assessment tool that they used to do, but and I have no reason to believe that things are any different, but several years ago, when they were doing an assessment tool to assess mental health needs, they found that over 75% of the boys who were in the state juvenile corrections facility had mental health, diagnosable mental health needs, and 100% of the girls had diagnosable mental health needs. So it's clearly the de facto mental health system here in Wisconsin as well, and it's that way for adults also. So why is our system constructed this way? Well, you would hope because it's best for kids, but that's not the case. So if it's not best for kids, maybe it's best for providers. And while it's probably a little bit better for providers than it is for kids, that's really not the case either. So, if we remember our definition of system, a set of things working together as parts of a mechanism or an interconnecting network to form a unified whole. Maybe it's most efficient, but that's not really the case either. And maybe it's cost effective, but that's not the case either. So why do we have this kind of system then? And I've thought a lot about this, and I can only come up with one reason that our system is this way, and that is because these are the structures we have. There's no other reason. We have a child welfare system, we have a juvenile justice system, we have state statutes, and it's because of this that we have this system. This is not what you would design if you were starting from scratch, clearly. And, Tim basically gave my presentation this morning talking about the need for system change and how it's pervasive across the whole state. So, having come to this conclusion, I decided, maybe despite all of these inefficiencies and that it's not really oriented towards kids and families, maybe we're producing good outcomes. So I decided to take a look at that as well. This is a 10-year view of access to public mental health services for children ages 0 to 12. The rates that are shown on the vertical axis are per 1,000 children with what's called SED. SED is a term that the federal government uses. It stands for serious emotional disturbance. I hate that phrase, have always hated that phrase, but it's pretty ubiquitous across the federal government. Interestingly enough, it's based on a definition. The definition that the Center for Mental Health Services, Federal Mental Health Center for Mental Health Services uses for SED is that they're persons from birth to age 18 who currently or at any time during the past year have had a diagnosable mental, behavioral, or emotional disorder of sufficient duration to meet diagnostic criteria that resulted in functional impairment which substantially interferes with or limits the child's role or functioning in family, school, or community activities. That's a pretty broad definition in my book. And while there have been people who said that kids with autism are not kids with SED. There actually is a federal court ruling that identifies kids with autism as part of this umbrella category SED. And that ruling is in the Rosie D. decision, in case anybody's interested. It was a case that was in Massachusetts about a decade or so ago. So clearly, we have a ways to go in access to services for kids, for our younger kids in receiving mental health services. So how about adolescents? And we can see that the picture is not really any better there. We're significantly below the national average. So now let's take a look at those community-based mental health programs and see, are we utilizing those any more than others? And you can see, I think that it's interesting that I've got the years switched. I apologize on that. But we're clearly below the national average on that as well. And also the one area where we beat the national average, and over this period of 6 years, we're about 3 times the national average. We put more kids in state mental health institute than other states do. It's the one area that we outperform the national average. So, not only do we have substantially lower rates of access to those services than average, we also have among the lowest parental satisfaction with outcomes from public mental health services in the nation. I have looked at selective years over this 10-year period, and we did find that Wisconsin was actually the lowest in most of those years. So if we're going to transform our children's mental health system, then we need to make sure that we understand what contributes to good outcomes, because clearly we're not doing it right now. There has been a lot of research that's been done in the last several years. And this chart comes actually from the UW Population Health Institute, looking at what kinds of factors contribute to health outcomes. And this same kind of work has been repeated by many researchers across the nation, and they've come to these same conclusions. And what it finds is that roughly 40%, the most influence on healthy outcomes, come from what are called social and economic factors, collectively referred to as social determinants of health. Twice as much influence on health outcomes as clinical care. Yet, if we take a look at where we spend our dollars, we spend it exorbitantly on clinical care instead of on those kinds of social supports. A major component of the social determinants is social connectedness. And this includes the quality of family and community support and civic participation. And so we, about 3 years ago, we did a research project with the Medical College of Wisconsin, and there were 3 nonprofits that were also involved. And we wanted to conduct a study to see what recipients of mental health services ranked, what they felt was most important. And the study found that out of an array of 11 service options, that peer support was identified as respondents as the most important service. It is identified as the most important service by a more than 2-to-1 margin over the next, which was psychotherapy. These results were consistent with the SAMHSA 2016 Awareness Day short report in which parent and caregiver support was rated as more helpful than respite care, case management, or individual and family therapy. In our research in 2016, respondents overwhelmingly indicated that peer support helped them feel less alone and isolated, connected them to resources, and empowered them to find their own solutions. And interestingly enough, one of the other things that this research, and it's not on this chart, but one of the other things that we wanted to find out was in the cases where people had received peer support, were they being referred to other mental health services? And in the vast majority of cases, that happened. In those cases where people had been referred to other mental health services by their peer support worker, the engagement rate was 96%. That engagement rate surpasses anything that we could find in the research literature, and surpasses it even when there are co-located primary care and mental health care physicians, and a warm handoff, that is a walking down the hall and introduction to the mental health provider, happens. This was a higher rate of engagement than even in those situations. So, this is just one element of those social determinants. But there clearly is some compelling evidence that these social determinants really do make a difference in the lives of kids and families. The respondents say so, and the data also say so. So, it appears that Wisconsin's children's mental health system is insufficient. We have among the lowest access rates in the nation. It's ineffective. We have among the lowest rates of satisfaction with outcomes. It's investing in the wrong things. We don't prioritize the things that people need. And with large, intractable structures in place, and I have to admit, the inexplicable inactivity on the part of the responsible people at DHS for mental health, the only way things will change is if we collectively demand it. And so we at Wisconsin Family Ties would like to invite you to join us in creating a network of concerned individuals and organizations in reimagining human services. We envision a system that provides services and supports of sufficient duration and intensity to permanently alter the trajectory of our most at-risk youth. We want to ensure that we never forget the human part of human services. We want a system that's built on deeper understanding of children and families and less judgment, and a system that views relationship as the intervention. One of the areas where we're going to start is to advocate for creation of a separate children's mental health code and statute. Wisconsin's Mental Health Act for persons of any age is called Chapter 51, as I mentioned before. It was enacted in 1975. Since then, our understanding of child and adolescent brain development has grown exponentially. We now not only know what works for adults is different than what works for kids, we know why. We know that kids are not little adults, and in Chapter 51, because it's all just one code, that's really what they're treated as. In the intervening 40 years since its enactment, Chapter 51 has been altered numerous times, and it leaves a tangled web of cross-references and convoluted provisions. And so we're looking to create a child and adolescent mental health code separate from the current Chapter 51 that ensures these basic things. The residential treatment specifically designed to address mental health issues. The model that we have, I mentioned it earlier, the model that we have in Wisconsin is the specific model is called residential care centers, and those are really designed to rely heavily on behavior modification, not to address specifically mental health issues. So, if any of you are interested in that same vision for human services and children's mental health, we invite you to join us. All you have to do is simply drop an email to our policy director. Her name is Joanne Yunke. I know it looks like junk, but it's not. Joanne Yunke, and her email address is joanne@wifamilyties.org. So that's all I have today, and I would like to thank Tim and the planning team for allowing me to speak, and it's been a great privilege to be with you today. Thank you. Sure, if you'd like. I know I'm a little early, right? Yeah.
So one of the things that we've asked the different speakers to do is come up with some sort of follow-up questions so that those at the viewing sites will have some direction and focus. But of course, we want to respect the local viewing sites. If there is a topic that is coming up at your local site, to please feel free to engage in that. This is not a my way or the highway sort of program. So with that, I just want to check with Hugh to see if there was from his presentation, stuff that at the local site may be able to be discussed to start to move us a little bit further down the line to healthfulness. I love the way that you brought in the social determinants of health. I think that's a really important framework to look at things. Health equity is an important framework to look at things. And I haven't heard it applied too much to the mental health system. So I really enjoyed that connection, because health equity is very important in a lot of other areas that I work in. But that being said, just trying to give you a little bit more time to formulate any questions. So anything that you think the sites would benefit from discussing? Remembering, of course, that we'll then be having that discussion here. So yeah. Well, I kind of ignored that task of identifying questions. I thought it would be rather presumptuous of me to come up with particular questions. I have some personal interest in finding out if what I talked about today is consistent with what people have experienced. I'm always cognizant of the fact that at Wisconsin Family Ties, because we are we're a complaint-driven or an issue-driven organization. That is, people are not going to call us when things are going well. And so I recognize that my view might be a little bit skewed because of that. But, we do work with 600 to 700 families each year. And so I think that that's a pretty good sample size to be able to draw some conclusions. But I am curious about whether people at sites, that might be something that they talk about. I'm also interested in, and this is maybe the big question that is really, really hard to answer. How do you, and you kind of alluded to it in your welcome, Tim. When we're talking about these things, we have these very complicated structures in place, and yet they're not really meeting the need. The evidence is really pretty overwhelming that it's not meeting the need. How do we go from that to something that does meet the need? How do we get not only the political will, but the public will to push for something like that? I think that would be a really interesting discussion. I don't have all the answers to that. Maybe somebody out there has something that would really help us move that forward in a compelling way. I think those are excellent questions, and with over 700 people spread out today throughout Wisconsin, it's possible that somebody has an insight that we haven't come across yet. So I'm hoping that maybe we'll be able to receive some of that input. And so I would ask that the sites, if you have a note taker as well as a discussion leader, would be fantastic. But if there would be some way, especially, we would love to know, are the barriers that Hugh was talking about, are those relevant in Park Falls as they are over in Milwaukee? Are there other barriers that maybe are more at the forefront for your community? We would love to know about those. The way you're going to let us know is to take notes and send them in. This is a one-to-many broadcast, and so we're not going to be holding a discussion with 700 people. As fun as that would be, we're not going to do that. And so please feel free at your sites to discuss the barriers, the local barriers, along with how do we get to a system that's going to work?